everyone. So it's a great privilege and honor to be here at the Visiting Institute. I'm very nostalgic. I was thinking in 2002, 2001, I was resident doctor at Rural Medical College, Lodi, and along with Dr. Paigar, we used to visit this faculty for development of community medicine department, and it's really great to see after so much of development in the campus, and I really appreciate the faculty members and the management for this great achievement. Second thing is that yes, I was medical teacher almost for 10 to 12 years. Teaching teaching is my passion. And after a long gap of 10 to 12 years, again I have got the opportunity to interact with the different students. And the most important and last, to see my old colleagues, my friends, especially Dr. Vijay Patil. He was my PG friend, was my roommate. Dr. Sudhir Pawar, he was my undergraduate roommate. Dr. Paigan, Mr. Paigan, they were my senior faculty member during my residency. Dr. Shubhra outside, your colleague in Rural Medical College, Lodi. Dr. Awali, so it's a really great honor. And when Dr. Outside called me, immediately I confirmed my availability for it. And I will really enjoy to interact with all of you. So in this talk, I will mainly focus about the advancing tuberculosis prevention, and I will only focus on the airborne infection control guidelines, and based on that guidelines, what was the different operational research that our research organization conducted, and I will also brief about the TB vaccine trial status. This is the institute where I used to work. Our institute, it was National AIDS Research Institute, that is NARI. It is one of the premium research institutes under ICMR. After devastating epidemic of HIV/AIDS, in order to respond to the AIDS problem in India, Ministry of Health and Family Welfare, they established NARI. Our institute has a significant research contribution, the research contribution in terms of operational research, epidemiological research, clinical research, various immunological, virological research. Based on research, our research finding, we have given guidance to the National AIDS Control Program for development of certain policies and strategies to tackle the epidemic in the country. The significance is we have contributed for development of WHO policy for take and treat approach. We contributed to WHO solidarity trial. Our institute is a recognized HIV drug resistance center for Southeast Asia region. Currently, so these were the contributions in field of HIV/AIDS. As the HIV and AIDS, yes, it has sustained, it has declined. Our institute has expanded its mandates in other viral infection, including dengue, RSV2, and other things. And our institute from NARI, it has become National Institute of Translational Virology and AIDS Research. You are getting, madam? I'm audible to you? Okay. So now on the occasion of World TB Day, India has National Strategic Plan for End of TB. This strategic plan, it focuses on 4 aspects, that is detect, treat, prevent, and build. Detect, the program officers, they have already explained. Treatment, yes, we have to opt for newer anti-tubercular drug, especially for multi-drug resistant tuberculosis, especially the shorter duration. In program, it's very challenging for any TB patient to take a medicine for longer duration. This is the main contribution for loss to follow and discontinuation of the anti-tubercular drug, and it is becoming the risk for development of MDR-TB. And the component to which I will focus is about the prevention component. If we want to prevent, what are the options available with us? Yes, tuberculosis prevention therapy. Sir has already, the previous speaker, he has already explained about the tuberculosis prevention therapy. The next one is airborne infection control measure. That is the one of the important area. then whether we have any opportunity for any licensed TB vaccine trial, and the last one is public health systems strengthening. So in my today's talk, I will mainly focus on the AIC guidelines and about the new TB vaccines. All of you know healthcare workers, they are having at more risk for development of TB as the occupational risk. And it is well known different systematic reviews, they have quoted the higher incidence and prevalence of TB among healthcare workers. And yes, there is a significant role of airborne infection control measures to prevent this occupational exposure. If we see the airborne infection control measures, there are different guidelines right from 2010. Various agencies, they have forwarded these guidelines. WHO has its own guidelines. The AIC guideline was developed in 2010, and recently in this month, March 2026, this recent guideline was developed. The main principle of this guideline, it remains same with some minor differences. So why this airborne infection control guidelines has to be there? These guidelines, it will useful for limiting the spread of respiratory infection. Then it should be for protecting patients and healthcare workers. And if we have these airborne infection control measures, the spread of respiratory illnesses like tuberculosis, COVID-19, it will definitely reduce it. And these guidelines, it provide the technical support for program implementers as well as care providers. This airborne infection control guidelines, it has total 8 core components. These are the 5 pillars and these are the infrastructure. So the first and infection guideline, it has a multi-level approach. What are the approaches at national level? What are the approaches at state level? What are the approaches at district and facility level? So this infection control, there has to be National Airborne Infection Control Committee. At facility level, like hospital level, there has to be Facility Infection Control Committee or Hospital Infection Control Committee. Each committee, they will utilize these guidelines and they will develop the guidelines at state level or at facility level. For facility level, they will develop the Facility Infection Control plans. Yes, then there has to be education and training components. In my research finding, I will show you what is the importance of education and training. The healthcare workers, they should be trained about all these aspects and how their capacity building will help to achieve. The surveillance has to be there for hospital-acquired infection, especially for TB. These guidelines also specify that the TB surveillance has to be conducted among healthcare workers or different healthcare workers, like healthcare workers in TB setting or ART center. It has to be biannual healthcare screening. We also conducted operational study about the acceptability of these TB screening among healthcare workers, and there are mathematical and monitoring and audit feedback. So the AIC guidelines, as I mentioned, the facility should develop their own infection control plan. So in that own infection control plan, these are the different activities that should be clearly specified. For each activity, who will do this activity, when it will be done, how it will be monitored, who are the responsible person, what are the process indicators for each activity, and what will be the ultimate outcome indicator that needs to be specified. In this guideline, there is a classical annexure that is given. If those who are interested, they can go through this part. The AIC component, it includes 3 hierarchies. There has to be certain administrative measures that need to be followed for prevention of airborne infection control. There has to be certain environmental control measures, and there has to be some respiratory protection. Now, what are these administrative measures? Administrative measures, yes, the facilities should have their own infection control committee. They should have their return plan. There should be adequate staff who will be the chairperson, who is the infection control officer. There has to be infection control nurse. There has to be linked nurse addition in current guidelines. there should be plan for regular facility assessment, whether a particular ward, whether a particular OPD, whether that is the high risk group for transmission of airborne infection. Remember, all of you are going to become a doctor. You will have your own OPD. In that OPD, you should have basic knowledge about the ventilation parameters. So the administrative measures, it includes this part. There has to be some measures that need to be done in OPD setting and in inpatient setting. There has to be tried, patient education, all these things I will discuss in the next slide. Inpatient facility also, the TB cases, there has to be minimum hospitalization, then there should be separation, other things, other ones have been mentioned. The most important part is this figure. What do you understand by this figure? Anyone interested in attending, like to describe this figure? You can use ChatGPT also. Here I have shown the sitting arrangement of the healthcare worker or doctor and patient, and here I have shown this is the airflow direction. This patient, he may be having TB symptoms. He will be coughing, and the air will be come from this south and it will go outside. So ultimately, through airflow, the TB bacilli, it will fall on weaker persons, and there is a risk of occupational exposure of TB. So this kind of arrangement is absolutely incorrect. Simple modification has to be done. Now in this modification, the doctor and patient direction is changed. It is into this direction. The air is moving from healthcare workers to patient, and then it is expelling out. That is much better situation. And ideal situation, here the airflow is in between doctors and healthcare workers. So these are the simple physical measures that one needs to be considered for preventing this healthcare worker infection. The second administrative part is where has to be trial. All of you know, if there is trial facility, it is observed in your hospital. In trial, we have to identify those people who are coming from respiratory symptoms. If someone is having respiratory symptoms, they have to be fast tracked. These are the different approaches for fast tracking. In this picture, you can see green line. What does it indicate? Those who are having respiratory symptoms, they will follow this green line direction and immediately they will be checked by medical. So such kind of approaches, each facility need to adopt. There can be a separate card for fast tracking of those symptomatic. There can be some assigned person for fast tracking of this patient. Of course, a second administrative is a cuff etiquette. I will not go into this details. Cuff etiquette. There has to be adequate masks. There has to be proper audio-visual messages in a local language, and the participants should, the people, healthcare patients, they should have this cuff etiquette. In for indoor patients, yes, there has to be AIC kit. This kit it contains disinfectant, mask, and put-up container. Then, this AIC guideline, it also specifies that the TB screening has to be done for these population groups. The recent guidelines, they have added this group. I'm sorry, I may not be properly visible, sincere apologies for that. But the population like undernourished children, elderly people, workplace, tea garden, construction workers. So at this stage, there has they should be screened. They are considered the high risk population, and TB screening should be adopted for them. Those who are symptomatic, yes, different kind of symbols can be provided to the patient. So these were the control. In administrative control, I have mentioned yes, there has to be facility infection control plan. It should clearly mention the various tasks, who will do, where it will do, what will be the monitoring thing, what will be the different progress indicators. Now we are coming to the next part about the environmental control. All of you know since your childhood, the ventilation plays important role in prevention of respiratory tract infections or respiratory pathogens. If we need to talk about the environmental measures, we have to consider the direction of control of airflow as I showed in the previous figure, and we need to calculate the air changes per hour. Now, what is air changes per hour? I will explain in the next slide. So there can be natural ventilation, mechanical ventilation, and heat ventilation. This is a simple single-sided ventilation. The air is coming from the same direction and it's expelling. It is not a good situation. This is considered as cross ventilation. This is the airflow direction and this is the air exit direction. And this is the stack ventilation. The air is coming from this side. It is getting heated. Then it expels out from the top of this thing. The mechanical ventilation here, there has to be use of exhaust fan. Remember, the exhaust fan, it has to be used with proper precaution. In healthcare facilities, otherwise it will have serious implications on this transportation. One needs to consider the airflow direction, one needs to consider from which side the air is coming out, how much should be the speed of exhaust fan. All these details are provided in this guidelines. In some facilities, the turbines and whirly birds, they are also available. You might have observed such kind of whirly birds. Then in some BSL-3, BSL-4 or TB, MDR-TB wards, these mechanical ventilation systems are in place that are highly sophisticated in BSL-3 and BSL-4. Then I was talking about the air changes per hour. Try to understand this concept. Now, say for example, this entire hall is there. We all are sitting here. So this hall has occupied some quantity of air. That air, it will get contaminated because of TB patient coughing. So this contaminated air, it needs to be expelled out, and the same quantity of fresh air has to be entered in this hall. So when this one cycle completes, the entire hall air is expelled out, the fresh air is entered, it is considered as air change. So in 1 hour, how many such air changes are occurring? That is the important quantitative criteria to assess the ventilation in any facility. So the facilities which are having high risk like MDR wards, ART center, such areas should be more than 12. Open setup, it should be more than 6. Now, how to calculate this area? These are the different equipment. You have to calculate the room volume, unit measuring tape. You have to measure the airflow. What is the velocity of airflow? From which window, whether air is coming from this window or whether air is coming from this window and going out. So for that purpose, you need to identify the airflow direction. You can simply burn a incense stick, keep it at the window, observe the smoke direction. You will easily get which are the inlet windows and which are outlet windows. These are the different calculations through which we can calculate the ACA. Then there are also other measures like cleaning air and filtration. These are recommended only if the natural and mechanical ventilation is not available. The respiratory protection is considered as a personal protective measure. Then I will not talk in detail about this respiratory thing. Now, which are the high risk rating? The ART center, MDR-TB, they are considered as a high risk rating. ART center, because here the people living with HIV, they are coming, they are already immunocompromised, and all of you know that TB is most common opportunistic infection in this population. And these TB patients, they are mainly undiagnosed, but they are source of TB infection to other immunocompromised patients as well as the healthcare workers. So at this facility, these AIT measures need to be properly assessed. So we conducted this operational research along with coordination with the National Waste Control Organization, and we assessed the different AIT and biomedical waste management practices at sanitary care facilities in India. We also try to identify what are the gaps and challenges the facility is facing to comply with these guidelines. So this survey was conducted across 95 HIV care facilities in 14 states. We trained the different public health scientists. These public health scientists, they actively consider, they calculate the air changes per hour in each room. They, based on their observation, they give recommendations to the healthcare facility. They observe what is the airflow direction, whether the airflow is obstructed by any furniture, and these recommendations were given to the faculty members. So these are some study findings. I will not go in the detail. Just one table I would like to show. So these are the administration measures that we assess. Some of these findings it was presented in World Health Conference in Paris. The findings will be published in next month in infectious diseases. So we observed that these AIP measures, there was gap in its implementation. The ultimate aim was, the ultimate finding was, by simple, visible, locally actionable measures can improve the AI. The importance is that the faculty, they should aware that yes, the airflow in their rooms is obstructed. They should be understood this concept of ACH, and definitely the recommendations they are easily accepted. We have given too many recommendations to this facility. We also taken the feedback from them, and majority of the facilities, they immediately adopted these recommendations. These were some findings pertaining to administrative measures. We also done a qualitative interview. We conducted in-depth interviews and focus group discussion among the ARC staff, and we tried to identify the challenges for implementation, but I will not go into the details. The second interesting study we have conducted here is air changes per hour in TB transmission from one family member to another family member. All of you know TB is a social disease. Different socio-economic factors, they are causing the TB transmission. In our study, what we did, we identified one family where there is a sputum positive TB cases. We identified their other household, those who are healthy, and this household were followed for 3 years. And in this 3-year follow, if any household develops TB again, it means that in that particular family, there is a sustained TB transmission. So we consider this family as a case. In the contrast, in the similar way, yes, the sputum positive TB case was there, but in 3-year follow, there was no, so it served as a control. So this match case control study, all of you might be learning your epidemiology outside, madam. I am sure shared definitely excellent nicely about the case control study design. I consider my teacher, so he might have already told all these things. So this case control design we have adopted, these were our exposure variable, individual characteristics, housing characteristics, because all these factors directly or indirectly it affects the causation of TB. We also consider the different housing conditions in your family visits. You might have assessed all these parameters during your family study. So we have done the logistic regression analysis in order to find which are the factors which are causing the continuous TB transmission. Sorry, so the ventilation, we observed that inadequate ventilation, living in a rented house, poor sunlight, these were associated with TB, continuous TB transmission in the family, and in adjusting of ratio, after controlling all these factors, we observed that if APS is adequate, if it is at higher side, it prevents TB transmission. So both this research, it highlights the importance of ventilation, the importance of fresh air in TB transmission, and that can be one of the components for TB disease. And one of the preventive measures we conducted was the clinical trial. It was India's largest TB vaccine trial, clinical trial. It involved total 12,000 participants, 12,000 participants. They were followed for 3 years and we observed the safety and efficacy of the vaccines. I will not go in the details. These are the different type of TB vaccines that are currently under different ways. For viral vector vaccines are there, protein HBV, wholesale extract, activated, MTB. I know all of you are hungry, so I will not. So this was our phase 3 clinical trial. Actually, we are expecting to declare the result today, but it has not yet resulted. The result will be published in British Medical Journal very soon, I think in next week or this 5 Monday. So all of you, I hope you know what is clinical trial, what is randomization, what is double blinding, and what is placebo control trial. So these are the classical characteristics of any phase 3 clinical trial. Any phase 3 clinical trial is mainly focused on efficacy of investigational product and safety is also important. So we observe what is the efficacy and efficacy of these two vaccines, TB and Immunovac. Among those who are household contact of symptom positive individual. If I am a symptom positive TB case, my family members they will be enrolled in the trial. Before enrolling, their TB status will be ruled out, and we administer this investigational product randomly to follow them for a year. And at the end of 3 years, these are the investigation product. This BPM 1002, it is nothing but it is a genetically modified PCV vaccine. Immunovac, which contains this mycobacterium W. This is a kill vaccine, while it is a live vaccine. This Immunovac is already licensed for use of laboratory in India, so we studied it repurposed use for TB prevention, and ultimately there was a placebo arm. These were the different inclusion and exclusion criteria. Remember, if you have to do about clinical trials, it would require extensive preparedness, extensive follow. So these are the different preparatory activities that we have conducted. Remember, any kind of vaccine trial, it needs a vast community activity. All of you know that there is a tremendous vaccine hesitancy in our Indian community. So they need to be properly counseled. As a health worker, we can directly approach and contact the community. There has to be some community advocacy, both different NGOs. That strategy one needs to define while implementing clinical trial. So, and being a regulatory clinical trial, it has some regulatory norms. There has to be data testimony board. If there are any adverse events, their tolerability needs to be assessed, their severity needs to be assessed, it needs to be entered into a data management system, and tolerability needs to be established. So, total 12,000 participants were enrolled in this trial. They were followed for 38. It was a huge challenge to follow these 12,000 participants after 3 years. The result will be published very soon. So, these two main parts about the Tier 1 infection control measure and TB vaccine trial, definitely we will have better preventive options and definitely you can end the epidemic. So, this is our team that where we are working. Thanks for your patience. Thank you. Thank you.